is Perry Gee. I am a registered nurse and a clinical informatics specialist. I teach at Idaho State University, and then I teach informatics at UC Davis and at University of Cincinnati online. And I did a study about, this talk is really about two different papers that I'm working on right now. One is about my research related to patients who are chronically ill who use electronic personal health records, and the other is about a model for e-health that I was inspired to look at after doing this study. And so we've been talking about this for the last couple days here, chronic illness. We all know what a serious problem it is. And for me, working in Idaho, there's one other issue, and that is that rural people who have chronic illnesses have worse access to care, and their illnesses are worse than their urban counterparts. So that's another serious issue that I think about as a rural person. And we didn't have a big push for electronic personal health records in the United States for many years. In fact, we got them going in the early 90s. People dabbled in them. I have 5 or 6 of them on my iPhone right now. And then Hurricane Katrina hit, and tens of thousands of people were displaced. And when they were displaced, their chronic conditions got worse. And they didn't have access to their records. They didn't have access to their medications. They showed up in emergency departments and clinics throughout the South with nothing. And their conditions worsened. And so we in the United States said, wow, we need to have policy. We need to have some kind of policy. Everybody should have a personal health record. Let's go do it. But we still are only sitting at about 7 to 9% saturation. Chronically ill people have a little bit more implementations, but really we're still sitting about 7%. Here in California, we're about 15%. So it's better than the rest of the country, but we're still not doing all that well. And then we really kind of forgot about it again until 2011 when the Tohoku, Japan earthquake and tsunami hit. This is a picture of medical records in a farmer's field shortly after the event. Obviously, these people had the exact same problems, and the Japanese government came to the United States, talked to David Blumenthal, and they said, what are you guys doing in the United States? We need your help with personal health records. So off they went to Japan to help them try to figure this out. But we didn't get very far. I put this up for impact, but this is, I think, a really tragic looking photo and very emotional photo of people in Japan leaving, and their chronic conditions worsened. And there are a couple different studies that showed that their chronic illnesses worsened after this event. We don't know if it's because of coordination of care or if it's just because of the stress of the event, but it's probably a combination of both things. So meaningful use now was implemented during this time frame, and we're trying to roll that out. And we said in stage 2 meaningful use, people should be starting to use portals at least. And so that's the study that I did. I want to understand, number one, why we weren't really having people use these systems very much. And number two, the people who are using them that have chronic illness, what are they doing? What is it about them that they like about the system? What can they teach us? And so that's what I wanted to understand. So I went to a group of internal medicine physicians, both in urban and rural Central Valley of California, and I said, can you give me patients that are experts at using these systems? I want to go talk to them. So I went to their homes and I purposely interviewed people who were good at using personal health records. Now keep in mind, this is quite subjective. And if you want to know more details about my methods, I'd be happy to talk to you about that, but I don't have time to talk a lot about my methods or my analysis. I want to jump into the findings here. And so here's what I found. I found that every single one of the patients that the doctors referred to me for this study turned out to be e-patients. And I think they're e-patients. That's my own idea. I have a pretty good understanding of what e-patients are, I believe. And I think they were e-patients. We don't have a scale for that yet, but that's somebody might be developing that as I speak. There were 18 people. I went to their homes and talked to them. They were between ages of 50 and 65. The average age was 60. They were educated. Most of them were working. They had about 3 chronic illnesses. They had 5 providers, though, and only about half of their providers were using electronic personal health records. So right there, you can already see there's some kind of an issue with that. Provider visits per year varied based on their chronic conditions, but they had a lot of visits per year to providers. And self-reported, they all told me they were strong at using the computer, they were strong at using mobile devices, and they were strong at using their personal health record. And so this is what I found, or these are the themes that I finally came down to. They are patient engagement and self-management, access and control over personal health data, promote productive communication, and seeing and seizing opportunities for exchange. And this is really similar, this engagement is similar to what other people who had done studies like this had found. So patient engagement and self-management, patients felt very empowered and engaged. People were very emotional about using these systems. They used them to track their test results or their other diagnostic studies. They used them for communication, obviously, with their provider. They used them to prepare for visits, so they knew what questions to ask when they went to the provider for a visit. Many of them suggested courses of treatment. So, hey, provider, I've been following my lab work. Do you think my medication should be altered based on that? So I thought that was interesting. They used it for preventative care and screening. They used it to help remind them about appointments and upcoming things. And then they loved the 24/7 access. So they really felt empowered using these things. They were frustrated, though, in the whole concept of interoperability. I had people who were at major medical centers in the Sacramento area who had specialists here in Stanford, and they said, well, our systems don't talk to each other, so I take a notebook whenever I go over and talk to my specialist. That was frustrating to people. Care coordination was a problem when you only have half of your providers using these systems. People were very frustrated, so every single person that I talked to kept a paper-based version of their electronic health records. They had design and navigation concerns. Every single one of them did. They were wanting policy change. For example, one man told me that he was struggling with severe pain. He takes narcotics frequently, and he has in his electronic health record that he has 4 drinks a day. But he only has 4 drinks a year, and he can't get that changed. He's tried multiple times, and every time he goes and sees a new provider that says, well, what about this 4 drinks a night thing? And he was very frustrated by that. So we have people finding lots of errors in their electronic health record because they have access now. This could be something that we can handle with policy change. The releasing of results, it depends on, again, policy at your organization, how rapidly results are released to patients. And patients told me they all wanted access to all records. One person told me, I want to know what they're saying about me, so I want to see the notes. Because this person had fibromyalgia, and they said, I want to know if they're taking me seriously. And then they want to be able to customize it, because if you're a person with diabetes, you have very different needs than a person who's doing chronic pain management. So they wanted to customize the system. They used it to promote communication. Messaging was very important. They didn't want to use the phone because the phone could be screened by somebody else or misinterpreted by someone else. They were confused, though, on who was receiving messages on the other end. So if I send an email message in, is it just my provider that's going to see that, or is it going to be everybody on the provider team? Message content was a problem. Some people wrote big, giant emails to their providers. The providers were frustrated and said they didn't know how to go through all of that. And they wanted to communicate with more than just a provider. Like some people said, I really only want to talk to my physical therapist or my dietitian or my pharmacist. So they wanted to talk to other people besides the providers. And the response time in my study was very good. I have very engaged, active providers in the group. But by the way, privacy was not a worry for anybody in my study. That was different than anything I had read in the literature. The people in my study said, I don't care about privacy, I just want to get well. So who cares about my A1C or my blood pressure? I just want to get well. So I thought that was kind of interesting. And then last, not a single person that I looked at, and I did a previous study before this one also, had received any kind of training. Most of them got a letter in the mail saying, here's your new system, we would like you to start using it. So they were all self-taught, they all learned by trial and error, and most of them said, wow, I don't know how people who aren't as computer savvy as me are going to be able to handle this. So there are opportunities to train for health literacy, numeracy, messaging, communication, navigation, and then people in my study did not use the reference material supplied by the personal health record. They used outside sources, so maybe we need to do some training in that as well. My study was based on the chronic care model that we know has been proven in a variety of different studies to be effective if it's followed, if the components are implemented. The problem, though, with the chronic care model, in my opinion, is it was developed in the late 90s, and it really doesn't take into account for e-health. So my goal is to try to include e-health in this chronic care model. And so before I did that, I had to figure out what the definition of e-health is. And there are 51 different definitions out there, according to the literature, of e-health. So I bet you everybody in this room probably has a slightly different definition of e-health. So I thought I would develop my own right now, and this is still a work in process, but related to chronic care or chronic illness. And I wanted one that is an e-health that promotes positive outcomes by using a new frame of mind that incorporates information and communication technologies in the presence of a complete feedback loop and enables the use of data and information to generate health management knowledge and wisdom. It's not all my idea. I took these as little snippets from other people's, including the original definition of e-health by Dr. Eisenbach. And so the mHealth or the eHealth components that I'm interested in, I'm sorry about the messy slide, are using the internet for health purposes. We already know that people with chronic illnesses, I believe 60% of people with chronic illnesses already use the internet, and 75% of those who use the internet found during their last encounter with the internet that they found something that improved the self-management of their health. So people are already doing this. Telehealth and telemedicine has been proven over and over again to be a successful e-health tool, including for those people who are underserved. A recent study by Riley found that people who had congestive heart failure who lived in the reservation area in northern Arizona had less returns to the hospital when they use a telehealth component or telehealth intervention. Social networking, we don't know as much about that, but we do know that JAMA published a study last year related to the diabetes online community to diabetes, and that they were able to help each other monitor hypoglycemia. I think this is a great starting point for research. mHealth, again, we don't know very much about mHealth yet as far as its utility in the research world, but we do know that targeted text messaging does work for people, and you don't have to have a smartphone or real expensive equipment to do that. Electronic health records, we're still only sitting at about 50% of the country has electronic health records that meet meaningful use criteria. If you want the state that has the most, that is North Dakota, 83% of them already there. And the least is New Jersey at 21%. So we have wide variations from state to state. And personal health records really don't do anything for primary research results, but they're secondary results like engagement and empowerment and things like that. So my chronic care model, how am I doing on time? Am I getting about done here? So I didn't pay attention, I'm sorry. My chronic care model has changed. So this is the same chronic care model. The components are all there. The self-management support, delivery system design, clinical system decision support, and clinical information systems are all there, but they're all been enhanced with eHealth. The umbrella now includes the e-community because it's not just the community anymore. These people are getting access to the e-community as we've been talking about here for the last 2 days. And then I included another component, which is education, because people are not trained. And I don't just mean patients, I also mean providers need to know how to train their patients, how to use these tools. And then most importantly is we found that if you don't have a complete feedback loop, and this is from the work of Holly Jemison, if you don't have a complete feedback loop, if you just have patients sending data and information into a black hole, then they're not going to use a system and they're not going to be successful. So we have to make sure that it includes a complete feedback loop to have those improved outcomes. And I think this is important because we already have big business now getting ready to ramp up their their association. We've all heard about Apple and Mayo Clinic working together. We've heard about Google changing their systems, and we've now been hearing that Samsung is doing the same thing. So all the vendors are getting ready to get involved. And I took this picture a couple weeks ago in Redding, California at the Best Buy, and there's an aisle for eye health. I didn't even know that that was a word yet. But here's an eye health aisle, and look at all this stuff. And our patients are going to go in there and buy this stuff, and they're going to ask us as providers, what do I do with that? So I think it's important that we get ahead of the curve, and we have some work to do. So anyway, I just want to acknowledge more than anything my participants in my study that were very sick, in a lot of pain many times. They had me come into their house. They made me coffee, and we sat for a couple hours and talked about their conditions, and I was really honored to get to do that. And are there any questions? Yes. I wish I knew more about the policy itself, about what happens. So what I did was, when I took my findings and I went back to the group that makes the policy at one of the large organizations I was working with, I told them about this, and they said, oh, you know what, there is something we can do about that. The problem was, it was just a problem of not the right hand not talking to the left. The people who were responsible for that were not necessarily the policymakers. So the analysts and the others that were responsible for the personal health record at that organization didn't have the power to get in there and make the changes they needed. So they just had to hash this out amongst themselves and figure out a policy. So what do we do when a person comes to us with those kinds of errors? And that was just at one organization. I'm sure this is happening at other organizations throughout the country. Yes. Yes. So this is in review right now as we speak. So as soon as it comes out, I'll let you know. I happen to be publishing this in the journal called Nursing Research, just a generic nursing research journal. So I don't know how to answer that. I'm sorry. Oh, I'm sorry. Yes, it's all the identified data, and really, this is a qualitative study. So all I have, the data that I have in there are comments and other qualitative, descriptive items that I picked up from the patients, or from my subjects. And then this model is also in review in a couple other spots, and so I don't know when it'll be out yet. We're still kind of revising a couple things on that. Any other questions? Thank you.